Hello, greetings. This is Dr. Bhomik again, and this is our third case of this presentation. And this is a pretty common case. You'll realize as I go through this case. And I have no financial disclosure to make. The photograph presented or included in this presentation in the slide format was taken after the complete consent of the parents and the patient, as well as keeping up abiding by the protocol of university. This case is a 14 years old African American male who came to your clinic for a physical examination, sports physical examination. And the routine examination was done as a part of the physical examination. And we did show the urine glucose more than 1000 milligram, but no ketone. His weight was 240 pounds and the height was 67 inches. Calculated BMI was 38 kg per meter square. Physical examination. The remarkable positive finding in physical examination is the dark pigmentation skin changes around his neck and axilla. Blood pressure was 140/82 and his pubertal development is near completion. Most important question you should ask in the clinic to this patient after getting those initial information. Obviously, you got to ask about the history of polyuria, polydipsia, and weight loss, and then whether how much sodas that he has been drinking, because the study has shown that childhood obesity or adolescent obesity is correlated with the significant consumption of sodas, either in the form of commercial sodas or juice or concentrated sugar form. And so in an average, they tend to consume about 6 cans of soda. History of physical activities is important. So is the family history of diabetes and hypertension is extremely important question to ask. History of heart disease, hyperlipidemia. And now this is the presentation that very interesting for you to see. And again, throughout the axilla, and you see how dark it is, and actually this is significant skin finding, and we call this acanthosis nigricans. Acanthosis nigricans. And the next view will be even more impressive. And as you can see that not only that it is dark pigmented, but it looks like there is a nodular or wreath formation, velvety feeling, some people like to call, as a, this is pretty severe form of acanthosis nigricans. And the presence of that is very significant. You did a random blood glucose in your office. It came to 308 milligram per DL. But next morning you got a fasting one, which was 180, and hemoglobin A1C was 7.8, and the reference rate is 3 to 6%. Now the question that we have to ask: does he have diabetes? Does he need a glucose tolerance test to make the diagnosis? What type of diabetes might he have? So we have to answer all this question as we go through, and how to differentiate between type 1 and type 2 diabetes. And what is the most dangerous presentation of type 2 diabetes in adolescent? Okay, let's try to answer the first question. Does he have diabetes? The answer is yes, because he does have a random blood sugar more than 200 and fasting blood glucose more than 126 milligram per dl. And this is the criteria set by American Diabetic Association. So he does fulfill the criteria. And in addition that, he has a hemoglobin A1C which is 7.8, which clearly suggests a persistent hyperglycemia, at least for the period of many months, 3 to 6 months. Does he need a glucose tolerance test? Of course, he does not need a glucose tolerance test. And actually, glucose tolerance test will make things even worse. So no glucose tolerance test is necessary in this case. What type of diabetes mellitus that he may have? Well, most likely it is type 2. He is African American. He is also overweight. He is going through puberty or near the completion of his puberty. Uh, so statistically, he is going to most likely going to have type 2 diabetes, but type 1 diabetes has to be ruled out, which we'll discuss a little bit later. And acanthosis nigricans suggests insulin resistance, and the presence of that clearly tells you that this patient has insulin resistance. But just to about question that acanthosis nigricans in skinny people or not overweight people also can be seen, and that could be a very bad sign of visceral malignancy, gastrointestinal malignancy, liver cancer, and so forth. So this is a question that if it is with the obesity, and so that suggests insulin resistance, much less common is skinny people or the children with acanthosis nigricans is visceral malignancy, and that has been asked in your board examination frequently. He does have a strong family history of type 2 diabetes, and he is morbid obesity. Any BMI 35 kg per meter square and above is considered in children or adolescent is morbid obesity. Now let's see how we can differentiate between type 1 and type 2. I put this one in a very uh, concise way so that it will be easy for you to understand and easy to remember. The prevalence of type 1 diabetes around 1 in 400. It goes up and down a little bit, but this is a good figure to remember, 1 in 400. Congenital hypothyroidism is 1 in 4,000. Congenital adrenal hyperplasia is around 1 in 14,000. So these are the figure, it's not like written in the stone, but this is something that if you just remember the formula 400, 4,000, 1,500, 1,400, just to give you some idea. Now, the onset is throughout the child. Yeah, standard textbook, if you read before, and they will say that it usually at the age of 5 or 6 or in that area. No, it does. We see lots of them even in the first year of life. But the 2 years, 3 years old presented with the type 1 diabetes is rather uh, common. So it can occur in any age. The family history is uncommon. Only about 10% of the time there may be family history, but it's uncommon, but it's very common in uh, type 2 diabetes. And type 2 diabetes also uh, usually present around pubertal age. And the reason it is pubertal age because puberty is the time for more insulin resistant. So period of puberty is the more resistant phase. And in some studies, they have shown that African American children, as they go through the puberty, they may have a little bit more insulin resistant than Caucasian. So going back to the DKA, DKA is common. As much as 15 to 30% of the type 1 diabetes may present with DKA. However, younger the age, chances of DKA is much more because sometimes they are not recognized as quickly as it should be. And DKA is more less common in type 2 diabetes, and they sometimes they are maybe completely asymptomatic, just like this case. And you can, just by routine examination of the urine, you can get the first clue towards the diagnosis of type 2 diabetes. Acanthosis nigricans is not common, but this is very common, almost 100%. Now, even in type 2 diabetes, this is very important to remember. You cannot call how obese they are. They may have acanthosis nigricans, type 2 diabetes, until you have shown that they do not have immune marker. So immune marker must be checked, or questionable diagnosis of type 2 diabetes. And if the immune marker is present, then they have a type 1 diabetes. And type 1 diabetes will have glutamic acid decarboxylase, GAD, islet cell antibody present, and that is very uh, important to check in especially type 2 diabetes, where you consider they have type 2 diabetes. What is the most dangerous presentation of type 2 diabetes mellitus? This is called hyperosmolar hyperglycemic crisis with or without mild ketoacidosis. They present with blood sugar for more than 1000, and they have a higher mortality rate than DKA of type 1 diabetes, and they lose excessive free water loss resulting in severe dehydration. We published a series of 7 cases of hyperosmolar hyperglycemic crisis, and including the fluid management and everything in endocrine practice journal. And one thing to remember, that in type 1 diabetes, we have taught you that you have to be careful not to give too much fluid. There is a chances of cerebral edema. But here, the water loss is so much, you really have to hydrate them really good. But in addition to that, many times, because of the excessive fluid of water loss, they have hypernatremia, and they do have also hypertension. So you have got double whammy. You have hyperglycemia, hypernatremia, and then you have hypertension. So one has to be very careful. And type 2 diabetes with hyperosmolar coma is more dangerous than type 1, and I'm repeating myself. So we will be discussing DKA in my later series of the lecture and their management. But I thought this is a very common presentation. This is a very commonly seen patient in pediatric clinic, family practice clinic, as well as in a pediatric resident is going to see in the outpatient clinic. So treatment wise, you really don't have to worry too much about that, but the standard one is metformin. The children with type 2 diabetes, metformin, but if they have a high hemoglobin A1C and severe hyperglycemia, initially they are going to need insulin, and it could be long acting insulin and with short acting insulin. But many of them, if they lose weight and with exercise, they might come off insulin slowly and gradually. Diet and changes of lifestyle is the most important thing that you can recommend. And so the dietary management and weight loss exercise is very important. Rosiglitazone, some of the type 2 diabetes treatment that is prescribed in adult, and many of the pediatric endocrinologists are trying to use that. But for your purpose, the the main treatment is metformin and insulin if necessary. Some additional comment about uh, girls with type 2 diabetes. Type 2 diabetes is more common in children, African American, Hispanic, Islander, Indian, and girls especially. If they have type 2 diabetes, they present with they may present with polycystic ovarian disease or polycystic ovarian syndrome, and there is a condition called metabolic syndrome, and which is more common in type 2 uh, diabetes.